always have invited speakers, usually from Australia. And this year it was Ian Sutton, Bruce Taylor, and Mike Boggold, who are three neurologists working out of different areas of Australia. It's always helpful to have their take on things, and I might mention some of the things that they spoke about at the meeting through the talk, just because it's fresh in my mind. So what I'm going to talk about today, move this out of the way, is the treatments that we have currently in New Zealand, and then a little bit about how we use the treatments that we've got, mention where stem cell transplant lies in the mix, and then talk about the future medications that are going to be available, hopefully in New Zealand soon. I haven't talked about the more longer term, so there's slides and slides we could put in about future availability of different drugs that are in development. So it's probably a different talk, but there's plenty of those, so lots to look forward to and be optimistic about on novel therapies. The current treatments that we have in New Zealand really target what we call active MS disease. So when we talk about active disease, which is a term that's pretty much interchangeable with relapsing remitting disease, we're talking about the immune system accessing the central nervous system, so crossing the blood-brain barrier out of the blood into the brain or spinal cord, and thereby causing damage to nervous tissue. And what we can see on MRI scans, you can see here on the spinal cord, 2 dots. So that's where the immune systems cross the blood-brain barrier and cause damage. Patients will experience active disease or relapsing remitting disease in the form of relapses, and the drugs that we're using at the moment, you'll see a slide coming up later, where our current available drugs reduce the relapse rate. So they stop patients from experiencing the immune attacks, and they reduce new lesion formation on scan. So interval scans, usually we do about a scan every year or so, depending on the treatment. And so, but year to year, you'd expect to see a reduction in new lesion formation. With the combination of stopping relapses and reducing new lesion formation on scan, usually that then translates into a reduction in the progression of disability. So most trials comment on relapse rate, new lesion formation, and disability progression. In the MS, progressive MS world, it's a different story. It's definitely an evolving phenomenon, our understanding of what progressive disease is, and definitely worth tuning into what Bernard has to say next month in the next webinar, because as the understanding grows of what is occurring in progressive disease, hopefully from that more effective and useful treatments that target progressive disease will come through. But currently progressive disease is thought to be a combination of old damage, so where a tissue's been damaged and then progressively gets the nerves stop working so well and die with time. Immune disease that's occurred in the central nervous system and then gets kind of pocketed away in there and grumbles, so sort of grumbling changes in a lesion. So for example, that lesion there, the immune attack from the peripheral body in has stopped, but it might grumble away there and cause slow disability over time. And the third thing is inflammatory change in the meninges and over the surface of the brain. So you'll hear more about that from Dr. Lim next month. But the diseases, although it's still all under the umbrella of multiple sclerosis, what's happening in the brain and spinal cord when people are in those different phases of the disease are very different. And that's why the treatments probably over time will become more unique and specific for the two different diseases. So currently in August of 2023, we have funded treatments for people who have active progressive disease or active relapsing remitting MS. And I borrowed this slide from 2 years ago and I haven't changed it. There's only need one clinical event now. So from last year, we had a really amazing change to the pharmac criteria that allowed us to start patients after just one clinical attack, and that is so much better. We don't have funded treatment for primary progressive MS, and I've remembered to put the brackets in and yet there because we're imagining that will hopefully go through on the 1st of October, or secondary progressive MS. There's no funded treatments for that in New Zealand. All the current treatments that we have available reduce the immune-mediated damage. So treat the active disease, reduce relapse rate, reduce new lesion formation. We don't have treatments that work for remyelination or healing, and no treatment that specifically targets the degenerative component of the disease. The other thing that I won't talk about so much today, but is incredibly important, and all of you will know, is the non-medical management. So going alongside with all the medical treatment that's targeting the immune system, preventing damage, is all the work that you all do on healthy eating, getting your sleep patterns right, exercising, keeping your spirits up. All of those things absolutely vital in MS management. And I'm just focusing on the medical treatments today. So in terms of what the eligibility criteria for funded treatment, we're really lucky now because the requirements are very practical in terms of individuals who have active relapsing remitting MS disease, mostly now can qualify for treatment. As you know, most of us can remember, because it wasn't that long ago, that people would be diagnosed with MS, the disease would be active, they'd have a relapse, they'd have new lesions on scan, and might not qualify for treatment. But now, if you have active relapsing remitting MS disease, as long as you've had the relapse in the past year or 2 in the last 24 months, you should pretty much be able to qualify for treatment. And if your sense is that you meet that criteria, so you have relapsing disease, you had a relapse in the past 1 year or 2 in the past 2 years, and you've had an MRI scan and the doctor said to you, look, your MS is active, then probably you should be on treatment. Just an aside, the Australian doctors that were at the meeting starting to pick out a few patients with very, very mild MS that they don't treat. Their current stance is to be very aggressive, using the high efficacy treatments and HSCT to treat patients with MS very aggressively, and often potentially not treat, so not often, infrequently, but sometimes not treating people who their senses have very, very mild MS. So there's still a way to go in deciding what is the best thing to do for patients. I've got a few slides coming up detailing what my current practice is, just to give you a sense of what I do, but it is still an evolving phenomenon, how best to treat people with active MS. So these are the medications that we have available. Natalizumab, which is given as a 6-weekly intravenous infusion. Ocrelizumab, which is given 6-monthly, also through an intravenous infusion. Our 3 oral tablets, so teriflunomide, dimethyl fumarate, and fingolimod. Fingolimod is the most effective of these 3. All 3 really class as moderate efficacy, but with fingolimod definitely more effective, and Tecfidera not far behind, and then teriflunomide further down on the efficacy front in terms of treating active MS, but does have some other advantages. So it's nice to be able to have a choice for different patients. Then we have the older therapies, the injectable treatments, Avonex or beta interferon and gluteramate acetate. So we use these treatments to manage multiple sclerosis activity. It's always helpful to think when you're using a medication, you know, what's the goal of this treatment? What am I aiming for? And in the MS world, there's something called NEDA, and that stands for no evidence of disease activity. So there's different stages of NEDA that MS neurologists or treatment trials aim for. So mostly in current practice in the clinic, what your MS neurologist or your neurologist will be aiming for is that they use the treatment to prevent relapses, that your disability doesn't progress, so that you have no evidence of disability progression, and we're aiming for no evidence of MRI activity. Certainly with time and as the MRI technology advances, the other thing we'll be looking for is MRI atrophy. So some of you might see that sometimes the radiologist will comment on either no atrophy, or they might see that at the level of a particular spinal cord lesion, there's some progressive atrophy. So we're starting to use that to guide our treatment a little bit, but in the future, we'll definitely have atrophy data as part of our understanding of how well someone's MS is controlled on their treatment. And now we're up to NEDA 6, so there's other measures of MS treatment control that are used for research, really, but potentially coming to clinic. The other thing that I always like to see, and definitely we do see on patients, particularly on high efficacy treatment, is this concept of CDI. So a few years ago, well, probably over 10 years ago now, the concept that a person who was on MS treatment could regain function and rehabilitate and reduce levels of disability was almost kind of not even considered a possibility. But as some of you will know, that these treatments are really effective. They allow the body to heal. And so some patients do get disability improvement. This comes back to what I was speaking about earlier about the sort of strategy to manage MS treatment in the clinic. So it used to be that we were kind of relaxed about starting MS treatments, and people took time to start and consider. And that's always a good thing to do, because as those of you who have been down this journey know, there's a lot to learn about the treatments. Often you're coming to terms with not only the diagnosis, but having to learn the complexity of the immune system and getting to know your neurologist. So there's lots happening. So it can be a real challenge to start treatment early. People sometimes use the word immediate treatment. So we're able to do this sometimes when patients, for example, are hospitalized with their first attack of MS. So they might be in hospital, get treatment for their relapse, and before they even discharge, start on the disease-modifying therapy. It's much more challenging in the health system as it is as an outpatient to get everything sorted with, you know, the blood tests, the MRI scans, the JCV serology. So it can take some time, but we know from the trials that if you start treatment earlier, so if your treatment is delayed because, for example, in these studies, you were started on a placebo, that your disability is always going to be less the sooner you start on treatment. And even if you start the same treatment, but it's delayed, there's persisting differences between patients that had a delayed treatment. So in this graph down here, you can see that ocrelizumab was started later in this group here. So the interferon group lost brain volume faster than the group who were on ocrelizumab, and that persisted even over time. So being on a high efficacy agent early, reducing the risk of losing brain volume as soon as possible, that's what we aim for in the clinic now. The other treatment strategy, so early treatment is one component to our treatment strategy. The other thing that is part of that treatment strategy now that wasn't before so much, and it's still developing, and the data coming in to support this treatment strategy is still being published, where it used to be that we were cautious and we started a safe, maybe milder drug at the beginning and watched patients to see how their MS would evolve. And sometimes now in 2023, that's still the right approach. But for the majority, based on this kind of data that you're seeing over here, it's largely believed that a high efficacy treatment should be considered in every patient. That doesn't mean that every patient should be started on it, but what you're aiming to do is avoid the need for treatment escalation. So you don't want to start a person on a drug that they're then going to fail because it's not powerful enough and need to go to another drug because you've lost time for that person, and their brain is at risk of being more affected by the MS than it needed to. So we don't, we want to avoid the need to escalate treatment. So we want to ensure that for those with aggressive MS, that we start them on a highly effective treatment early. The other thing that we don't do in MS, which is done in some conditions, is start a very powerful drug and then drop down to a low efficacy drug, because we know that if you gave, for example, natalizumab for 6 months or a year and then drop down to Avonex, that the MS disease is going to rebound. So we tend to maintain on high efficacy medication rather than give a strong drug to start with and then drop back down. This is still kind of not really known, but it's sort of vague estimates. Probably about half of people with MS need to be on high efficacy drugs, and then 25% of patients would be likely to be controlled on moderate efficacy drugs, and then there might be a percentage that are fine on the milder treatments or no treatments, but that it's very difficult and challenging to pick the patients that are going to fall into which category. This is kind of how we sort of stagger our drugs currently. So low efficacy glutaramate acetate and the beta interferons, moderate efficacy and lower risk, so lower risk of side effects, dimethyl fumarate, tecfidera, and teriflunomide or Aubagio. And then the ones, our high efficacy drugs, we only really have two, but high efficacy and with higher risk. So when you read about these drugs, the side effects, the potential side effects are much more significant. And fingolimod, it kind of really in here, but it kind of edges into a higher efficacy treatment. But mostly fingolimod and ocrelizumab have quite similar, they work quite similarly, and probably you're going to go for ocrelizumab above fingolimod, especially if you want a high efficacy agent. This was a table I was talking to you about before, looking at the efficacy of all the different medications. It was published quite a long time ago now, but this is kind of the the staggering of the drugs. There's never been any real head-to-head trials, so it's all, our understanding of the efficacy is based on compared, like a table of the different trials. So how do we know whose disease is more likely to need high efficacy? There certainly are risk factors that have been identified that can help us gauge this, both patient-related factors and the way the disease is behaving itself. In saying that, you can take all of this into account, and there might be a patient who doesn't meet any of these patient or disease factors, and their disease breaks through the lower efficacy drugs and needs high efficacy treatment. So this is just sort of guidelines. It's how we kind of think about things. So, for example, the types of things that might predict that a person who gets MS might have more aggressive disease if the person is older at diagnosis, if they're male, if they have other medical comorbidities, obesity and smoking. And disease factors, things like if your relapses are disabling, so once the relapse is passed, if you have residual disability from that relapse, it suggests that the MS attack is reasonably disabling. And so you want to treat that aggressively to prevent disability accumulating from the relapses. If they've accumulated disability at 5 years, that's something also concerning. If the treatment's delayed, so in New Zealand, there are patients, for example, who weren't able to have treatment initiated at diagnosis because of the criteria we were working with. So individuals who've had a delay to their treatment, that might really push you to starting a high efficacy treatment. Cortical lesions, or the high number of spinal cord lesions, and then what we call T1 lesions, so a particular type of MRI imaging where you can see that the lesions aren't only just a superficial shadow scar, but it's a punched out damaging MRI lesion. And atrophy, which is shrinkage of brain or spinal cord tissue. So if the tissue's shrunken down and been lost, that's also a sign that the patients are more likely to need high efficacy treatment. So currently, what do? I tend to try to use natalizumab and ocrelizumab for patients who have certainly moderate or severe disease based on the factors in that last slide. If patients are JCV positive, I tend to use ocrelizumab as first line. And I'm happy if people are positive but low titer, so under 0.9 would be fine. The Australian neurologists were saying they're pretty relaxed about JCV positivity on natalizumab these days. They think as long as we dose 6 weekly, the risk of PML is so low that they're not too concerned about that. So they still use quite a bit of natalizumab in patients who are JCV positive. Yeah, so that's also the statistics around that and considerations of that are also still evolving. But in New Zealand, we're lucky we can choose natalizumab or ocrelizumab. We do certainly rely on the JCV to guide which treatment is likely to be safer for an individual in the long term. For milder disease, I tend to use dimethyl fumarate, particularly in women of childbearing age where the plan is to stop treatment in pregnancy. You can dose that one to the point of pregnancy, and in the future, more and more now there's evidence you might even be able to stay on that one through pregnancy. So I tend to use dimethyl fumarate. It's a very safe medicine. I think I'll probably use that one in the treatment group that the Australians are saying they don't treat, but it is an evolving area. Fingolimod, again, it's a very good treatment of MS. It's certainly sits around the outside of the higher efficacy treatments. It's quite challenging in women in terms of those who are planning to become pregnant, because you need to stop the treatment 3 months before you become pregnant. You can't use it through pregnancy or breastfeeding. So it has its challenge in women of childbearing age. So it's potentially useful in men who don't want to have an intravenous therapy. The teriflunomide is just nice to have as another option, because some people, for so many different reasons, can't have any of the other drugs. So definitely we have patients in New Zealand on teriflunomide, but they would be in the minority. What about AHSCT? Again, evolving data on AHSCT and where it fits. But in New Zealand, we do have it as a potential treatment option. Where it sits really is in the same group as we're talking about. So patients with active relapsing remitting MS, where the immune therapy is, and powerful immune therapy is needed to stop immune attack on the central nervous system. So currently, it's accepted practice in MS, and the haematologists in New Zealand have met and agreed that they're on the same page as the American Society for Bone Marrow Transplant, who said that AHSCT is is appropriate for treatment refractory relapsing MS with a high risk of future disability. In New Zealand, we have criteria for this. So these have been agreed upon by a group of MS neurologists and presented to the New Zealand Neurological Association of New Zealand last year. They're based on a single clinical trial called the MISS study, which is a randomized controlled trial, but also on other published evidence. There's lots of case control studies, and also using in conjunction with what other centres are using, who have more experience than we do here in New Zealand, and selection criteria that's used for treating people with MS with HSCT. Our current criteria does have an age range. This is more to do with what's based on two things. One is the safety of HSCT, and also the likelihood that MS is going to be more active, more immune mediated in younger people. The similar argument on the disease duration. So under 15 years from first clinical event is again based on the fact that MS disease becomes less immunologically active in terms of what's targeted by an HSCT. Patients need to have evidence that their MS is breaking through a high efficacy treatment. So high efficacy treatments in this include natalizumab, ocrelizumab, ofatumumab, alemtuzumab, fingolimod, and cladribine. So if you're on one of those treatments and you have a clinical relapse, so you have a relapse event and you have evidence of changes on your MRI scan, then you could potentially need an HSCT, and that would be important for your neurologist to consider, as long as your level of disability is between 0 and 6. The HSCT criteria, each patient, if a patient meets this criteria, they are then put forward for further discussion with a committee of MS specialists to ensure that, yes, an HSCT would be appropriate for them. And that's considering it from a neurological point of view. And then obviously the procedure itself is done by haematologists. So there's a whole further assessment needed for consideration of treatment by a haematologist. So it's quite an important series of steps of thought and consideration that goes into recommending people for HSCT, but there's a path there that we have available to us in New Zealand. So what about the future? So as lots of you will have heard, it is likely that ocrelizumab will be funded for the treatment of primary progressive MS from October. The pharmac criteria for this at the moment are primary progressive MS meeting the 2017 McDonald criteria with an EDSS score between 2 and 6.5 with no history of relapsing remitting multiple sclerosis. I just put in here the primary progressive diagnosis criteria because it is important to be clear on that. So patients need to have had 1 year of disease progression and then have lesions in the brain that are typical for MS, as well as 2 or more spinal cord lesions and CSF that's positive for oligoclonal bands. And then every year when the renewal occurs, patients would still need to be able to walk that 20 metres without rest with bilateral assistance. I just put in here too, it's important to remember what patients were included in the original trial of ocrelizumab for primary progressive MS. So patients that were included on average were in their mid-40s. The range of ages was between 20 and 56. It was about 50-50 male and female, and time since the MS started was a mean of about 6 years. EDSS score ranged from 2.5 to 7, so on average about 4.5, and about 30% of patients, 25 to 30, had evidence of active disease on their MRI scans. The other thing that's important to remember when we're thinking about using ocrelizumab for people with progressive MS is that over time, so you can see time along here, over time, patients on placebo, so this is people who didn't get treatment, they got placebo, they continued to accumulate disease or disability. So this is 24-week confirmed disability progression. So patients still became disabled on placebo as well as on ocrelizumab. So patients on ocrelizumab did continue to get worse and accumulate disability, but the accumulation was less in those on ocrelizumab when compared to placebo. So what this tells us is that ocrelizumab does have some effectiveness in treatment of primary progressive MS, but it's certainly not a highly effective treatment as it is in the relapsing remitting form of the disease. The other medication that we don't have yet, but we're hoping to get at some point, is cladribine. This probably again sits in the moderate efficacy realm. The efficacy is from the clinical trials are a 57% reduction in relapse rate and a 31% reduction in 3-month sustained disability progression. The thing that's quite good about this as a drug is the way that it's dosed. So you can see in this table over here, in year 1, you take tablets for 5 days, and then you have weeks 2, 3, 4 off, and then in week 5, you take 5 days of pills. Then in year 2, you do the same thing again, and then you don't have any active treatments for year 3 and 4, and your MS disease is modified. And then subsequent to that, you would then need to start on a different treatment. And that does make it quite challenging for patients and neurologists as to what to do at that point and making sure that we're careful to monitor things. It's just nice. It's just another interesting and unique option that, given all humans are different and all MS is different, it's good to have different options to use for that to meet the different needs of people. So in conclusion, all the current available therapies work to prevent new immune-mediated CNS damage. What we do currently is look to identify those with aggressive disease early, treat early with the high efficacy medications if this is appropriate. For those who have mild disease activity, we usually start a moderate efficacy treatment, also early, and monitor closely. If a person's on a moderate efficacy agent and has the option of high efficacy, we watch very carefully to look to see whether they're having relapses or any MRI activity, and get them onto a high efficacy agent if required. For those who fail our high efficacy treatments, we're lucky now in New Zealand to potentially have this option of HSCT, and that's something that we look for in someone who's if someone has a relapse on natalizumab